Good afternoon, everyone. We are just about ready to get started. We're going to wait for a few more participants to be added to the group. So just a few more moments. So good afternoon to everyone. My name is Donna Houle. I'm a senior director here with the Military Women's Memorial, and we are very pleased to partner with the HunterSeven Foundation and bring you She Who Born the Cancer Battle and a series of webinars to discuss the cancer battles relative to men and women in the military, with a focus toward women in the military. And with just a little bit more about the Women's Memorial. The Women's Memorial is a national memorial and education center located at the very entrance to Arlington National Cemetery. We honor and tell the stories of all women in the military, all branches and all time. We do everything from discussion programs to book signings to exhibit openings, film series, tours, everything that is built to inform and educate the public on women and their service in the military. I'd like to hand this over to Chelsea, and she will do introductions on the HunterSeven side of the house.
Thank you so much, Donna. And for those who haven't checked out the Women's Memorial, please do check it out once you guys reopen. I don't know if you have a date yet, but it is one of the most incredible experiences that I've ever experienced. And the historical piece of it is definitely admirable. You guys do an amazing job. So thank you for allowing us to come in and speak on behalf of, female veterans. And we're very proud and honored to do so. So my name is Chelsea and this is Jack. And, we're going to run through, different types of cancers, preventative screenings. We're going to allow for a Q&A session. And so historically, we are both nurses. Jack is an advanced practice registered nurse or a nurse practitioner. I focus on the clinical side, and both of us have done time in the hospital as well as the military. Jack served as an intelligence operator in the Army, and I served as a flight medic. So, and then back to the Women's Memorial. Like I said, great experience. Highly recommend it. So thanks again. And a little bit about what HunterSeven does. We focus primarily on clinical research. Early on, we noticed that there wasn't a huge concept for research, and there's a huge gap in knowledge. So what we do is, on a preventative level, primary prevention, we try to conduct that research that's missing to bridge the gap. And then from there, of course, educating the population. So educating fellow veterans, providers, active duty service members, and so on. But we also provide immediate needs support. So those who are battling cancers and any type of needs they need met, whether it's second opinions, you name it, we make sure we get that squared away for them. And saving lives is our primary mission. So with that being said, unique demographics of women. Females continue to increase their presence in the military. I want to say average between 12 and 21% of post 9/11 veterans were females, and that's a number that has far surpassed anything that we've seen before. I think it was 12% was the lowest in the Marine Corps, and then upwards of 20% collectively. So women are more so on the front lines. And yesterday was actually an interesting day because yesterday was the birthday of Navy Special Operations Intelligence Analyst Shannon Kent, and Shannon's buried in Arlington. And Shannon had been in the military for a while, and it says there that in 2015 females were allowed to serve in any MOS, but before that, a lot of women were still on the front lines. They were still in the depths of combat, like Shannon Kent. And it was unheard of, and it wasn't really talked about. So women have been doing these kind of jobs for a while, just at a different capacity, and now it's becoming more highlighted. And I think recently there was a special operations. I know we had a few female rangers go through, ranger school, and so things are changing, but our women are increasing in population, and so their healthcare needs need to be, met.
So yeah, there has been a 175% increase in females utilizing the VA services. That's from 2000 to 2015. So significant increases, but that still leaves, there's actually still about 78% of female veterans who do not receive any of their care from the VA. The VA has made great strides. They are trying to set up women-specific centers at a lot of the main campuses and a lot of the auxiliary locations. But we're still not, for whatever reason, we're still not able to reach that demographic very well. And then there could be a number of variables to that. So the focus of today's conversation, which we kind of want to talk a little bit about the two of the different types of prevention. We have the primary prevention. This is the first line. This is before there's an issue. So kind of this is where we can look at, as an individual, this can be avoiding exposures, this can be avoiding scenarios that would put you at risk for a certain disease or problem. This can be at an organizational level, and this can even be at legislative levels that we can have that type of prevention. So this would be where the military would, either as an individual, I would choose to wear gloves, or the organization would then tell us that we had to wear gloves, or now it could even be legislated that we'd have to wear gloves, just as a silly kind of example for that. And as an individual, you can practice primary prevention by improving your diet, your exercise, and mitigating risk factors. This one is often forgotten. Just taking care of yourself can have super protective effects on, your immune system and your ability to ward off having any kind of chronic illnesses. And yeah, and then as organizations, one of the more important things, a lot of organizations, military included, they have a lot of really great policies that if we followed those policies, and if we were provided the tools needed to follow those policies, we would be able to practice a more primary prevention approach. One example of primary prevention is if we go through vaccination. So one of the things we're going to talk about today is cervical cancer, with HPV being the most dominant etiology. So active duty service members are less likely than civilians to get the HPV vaccine. It's about a 4% difference, which doesn't seem like much, but 4% on a larger scale, especially when you're considering that more active duty service members are younger. So those would be the ones that would have had access to the vaccine their entire lives, and then really are especially when you consider the STD rates and everything, so very much exposed to it. HPV is the cause of 3% of all cancers in women. So with the virtually all cervical cancers are related to HPV. And then risk for cervical cancer is decreased 88% for those who are vaccinated before the age of 17. There's actually rarely any preventative measure we can do that can prevent that high of a level of disease. So 88% is unheard of, and really, I can't think of another example of that.
And what's interesting is that, given how small, we discussed this on part one, is considering how small the military female population is in comparison to the male, cervical cancer is still the #1 diagnosed cancer in post 9/11 veterans across the board, across the gender. So with that being said, what's interesting with primary prevention is the ability to screen for these cancers. So we screen for certain cancers like skin cancer and like cervical cancer as part of our regular, female, annual appointments. So screening is imperative, and this is the exact reason why, because it decreased 88% for those that vaccinated before 17. So things like the HPV vaccine are definitely imperative in preventing cervical cancer.
All right, and then primary prevention, specifically for lead and heavy metals. Some facts about lead and heavy metals. Increased urine magnesium has actually been associated with increased breast density. And there's been a lot of debate on this, on how much breast density actually affects, cancer occurrence. But earlier on, there were a lot of studies and a lot of professionals who really believe that breast density was a major indicator for actually whether or not a tumor would have ended up being cancerous. That would have been an indicator, not a cause. Lead exposure has also been associated with increased rates of female breast cancer. There's been some small studies to kind of correlate the two. And lead may also contribute to progression and sensitivity to treatment of breast cancer. This was a really interesting fact, and I won't get into too much of the hormonal balances and things, but the lead exposure can actually cause hormonal imbalances that can lead to there was a progression in the cancer, and then an actual decrease in sensitivity to the chemotherapy treatments that we'd be administering. So it's a very interesting balance there, and we need a lot more research on that to speak too much more definitively. Cadmium, mercury, and lead may also contribute to increase for postmenopausal breast cancer specifically. So there's a couple different types of heavy metals, and one of the more common places you would be exposed to small heavy metals would be on the range. So everyone in the military, you're going on the range, you're firing, and as you're firing, a lot of people don't consider that you're aerosolizing all these tiny metals, and then you're breathing it in, you're ingesting it because a lot of people have food and drinks and things right there next to the in the range area, so that lead is landing on it. So you're taking a sip of your drink, you're actually taking it into the GI system, to the respiratory system, and then also even absorbing it into your skin. So mitigating those. The military has a lot of really good policies that we're supposed to be following with range procedures. I know when I was in, I didn't follow any of them. I didn't even know they existed. We're actually, one of the things I found interesting was you're supposed to change all of your clothing before you leave the range. I've never, ever, ever done that.
That's a good point, because and to add to that point, when I was in service and I broke my back, I went in for surgery, and they took some of my blood, and I was young at the time. I was in my early 20s, and they said to me, "Your lead levels are through the roof." And I said, "Oh, that's weird. It's not like I chew on lead paint chips. I don't understand why." And it was because I was the NCOIC for a flight line that was doing firearm shooting and airborne operations where it was live fire ranges. So I had no idea. Thinking back now, it's terrifying. And what's even more intimidating is, as the years went on, I asked, it came back, and I said, "Hey, can I get a lead test when you draw my blood?" And they said to me, "Your lead levels are fine." And so looking back at the information, how did my lead levels go from being so high to so low? And you think about how the body works, and if you can't necessarily filter a heavy metal through your kidneys, so it circulates and circulates, and then it can enter your bone. And that's the biggest concern with this. And those are all things that we need to think about is, are we washing our hands after we handle firearms, after we handle, munitions, or after we fuel a vehicle or anything? All those things are extremely critical, and the smallest thing can make a difference, because it's what the eyes don't see can be detrimental to your health.
Absolutely. All right, and then tobacco use. This one, I know most people have kind of had this beaten from a young age. Tobacco, we've known that it's bad for a very, very long time. The reason this is still so important is that 21.1% of active duty service members are still current smokers. 1 in 3 cancers diagnosed in the US are related to smoking. So having the prevalence of, this is one of the singular most important things you could do for your overall health, and then your actual risk for developing cancer in the future is just eliminating tobacco use. It's not minimizing, it's absolutely eliminating is the goal. So exposure to combat and the history of mental health disorders we're both predictive of smoking initiation. They did a study, I think it was 2017 study on that, and they found that people who had the actual combat deployment histories, those guys would come back and they had a significant, wish I wrote down the percentage, but it was a significantly higher percentage than those who had not had the combat exposure. So that was a unique predictor. And now with women are actually now equal to men in their risk for lung cancer, COPD, and cardiovascular disease related to smoking. Typically and historically, that's always been males. It's been dominated by males. If you look back at the CDC data, they have some really cool trending charts you can look at. And it's men have pretty much stayed about the same for several years, all with a slight downward trend. But now females have increased enough where they're matching up. So of course, you know, educating veterans and active duty service members on smoking cessation, that would be the number one thing that we could do. Even as, you know, as veterans, we probably all know somebody that's still in, and we definitely still know those of us who got out. So take advantage of a lot of programs. The DoD, the VA, insurance, a lot of the state programs offer low cost or free NRT, which would be like nicotine replacement therapy. So you can get patches, gum. They even have, for guys that do the chew, or females, whoever does the chewing tobacco, they even have like fake pouches now that you can use. Yeah, and coffee, absolutely. So there's a lot of different things you can do, but it still has a kind of cool factor in the military, and that's something that we kind of have to combat a little bit.
And what's interesting about the smoking is that, you know, you don't really think about it, but my husband, who's also a fellow veteran, he picked up smoking while he was in service, and he said it was a way to get free breaks than others who didn't smoke. And it was the most asinine reason I've ever heard, but it makes sense. And so we completed a study that showed you're more likely to smoke while deployed. I think it was 41% while deployed versus like 23 after returning from deployment. But this is something females do too. I know a lot of female members who smoke in the military, but when you think about it, it's a direct route into your oral, your esophageal, your respiratory systems. When you're smoking, everything that you're breathing in is not just the nicotine, but it's also the vector, whether it's on your fingers, whether it's particulates in the air. It could be anything and everything. It's really incredible on a health scale to see all the exposures just from smoking alone, and not necessarily tobacco, but everything else in your environment.
And that was those were a couple. There are a thousand ways you can practice good primary prevention. Tried to narrow we could have probably had an 8-hour talk on just primary prevention alone. We tried to narrow it down to a couple like achievable goals that we could look for. Now we talk about secondary prevention a little bit. This is something where we've already kind of failed to prevent the cancer, and now the goal goes into early detection of the cancer. So we'll kind of deviate and talk specifically just about cancer right here. Screening for cancer is the cornerstone of secondary prevention. One of the most important things you can do is follow the guidelines and be screened. Screening is not, and this is where a lot of people misunderstand what screening is. Screening is not when I present with symptoms. Now we're testing. Screening is when I don't have symptoms and I go to my doctor for my checkup and we do XYZ for whatever type of cancer we're screening for based on your demographic. That's what screening is. Military provides universal health care for all active duty service members. So you have, in theory, you have access to screening. As all of us know who spent any time in the military at all, that's definitely depending on the tempo, the deployment, and duty stations. Also, not even to mention, just kind of stigma related to going to the doctor often, because some of these you need follow-ups, you need multiple appointments. You'll go to your doctor, he'll say, or he or she, whoever will say, I need you to do a low-dose CT, you have a history of smoking. Then you have your low-dose CT, then they got to read you the results. So now we're talking 3 appointments. And then the 4th appointment, they might say, hey, now we need to do a biopsy. So that's an even longer appointment. So now we've taken 4 or 5 days for one type of screening that can take you out of work. And unfortunately in the military, I know that was the stigma when I was there. If you even went to sick call just one time, that was, it was frowned upon.
Especially for females. I've seen that very often, female veterans or female service members who go to sick call or go to medical, and it's just that adverse outlook as though they can't hack it. But listen, nobody's going to care for you like you're going to care for yourself. And there's just so many different things that you can do to make sure that you're at the prime state of your health. And the other thing is be your own best advocate. I mean, secondary prevention requires you to put in a little bit of effort. You know, you got to go to those annual appointments. You got to speak up about, hey, listen, this is kind of new. Can I have it documented for one? Because if it's not documented, it didn't happen. That's medicine 101. So make sure it's documented. You know, for me, I was like, hey, listen, I got this severe acid reflux and I don't know what's going on. My diet hasn't changed. I'm still working out the same. I'm not drinking alcohol. I'm not sure what's going on. And it was documented. And eventually that led down the line to being tested for H. pylori, which, you know, these are all screening things that we can do and advocate for ourselves that can assure that we have a life longevity and healthy lifestyle. So, I mean, the mortality rates are incredible. Like an 11% mortality rate on average when cancer is detected early. So stage 1, stage 2, even localized. That's a good, I'll take that percent. That's a good percent.
Yeah, and actually, unfortunately, we're going to talk about that on some of the next slides, and how decreased the mortality or increased the mortality rate gets with later detection. So individual screening recommendations are specific to the relative risk and evidence-based. So there is the U.S. Public Health Task Force, which is kind of like, that's one of our gold standard places that we look for what type of screenings we want to do. Now, every major, there's the American Gynecological and Obstetrics group. There's the cardiac, every group has their own gold standard that makes recommendations on what type of screenings we should be doing for whatever chronic illness. But U.S. Public Health Task Force generally has, I guess, they would kind of have more of a middle ground of a lot of them. They do a pretty good job collective putting the right evidence in. So determination of screening eligibility is something that's pretty important to talk about. This is based on your medical history and relevant exposures and unique factors. So the only way your doctor knows any of that stuff is if you tell them. So with a screening, if you come in and you say, hey, it's all good, you don't talk about the fact that you were in the military, or you don't talk about the fact that you worked in, you were a diesel mechanic while you were in the military. You don't talk about, the fact that you were exposed to XYZ, whatever the exposure may be. Your doctor has no idea, and they're not going to screen you any differently than they would someone else, a civilian who didn't have those unique exposures. So it's important to take the time to actually talk to your doctor, even if they don't inquire about it. Make those things known. Make sure that they're aware of those things. Try to establish a good relationship doing it, but make sure that they do know those things. And overscreening. This can actually be dangerous. A lot of people ask me, one of the questions I get asked pretty often is even specifically with like lung cancer, low-dose CT. Low-dose CT is a very low dose of radiation, and it gives us a really good picture of your chest. People ask me, well, why don't we just do that every year for everybody? Well, the problem, not only are you then dosing yourself with radiation, but then we even have to start talking about what happens when we see something. And we'll talk about later about how many nodules actually are, we're not really sure they're cancer a lot of times until we do a biopsy. So now we're doing extra biopsies. And every time we do a lung biopsy, if you've ever seen this procedure, it's not it's a super invasive procedure that, can cause major long-term issues if it's not done correctly, or gosh, even if it's done correctly, there still can be poor outcomes. So overscreening is actually the inverse problem. We try to find a balance between the two. One of the things that was interesting I brought up when doing research for this is that a lot of providers, most providers in this study did recognize that the U.S. Public Health Task Force recommendations were important. 65% of them admit to recommending breast cancer screening annually rather than biannually. So that was interesting because there was, and we'll talk more about the screening requirements specifically, but they were offering it more than what was recommended. So are we balancing off? Is this because those doctors had women who had unique exposures, or is this because the doctors were uncomfortable, whatever reason it may be? Now, there's been follow-on studies just to kind of see what the repercussions of that have been.
The interesting part about that is too that the average American is exposed to, I want to say it's 3 millisieverts of ionizing radiation annually, which is pretty common. Obviously, it's more in places like Japan and Afghanistan. But when you go for a CAT scan, one CAT scan, even though it's quote unquote low dose radiation, it exposes you to 25 millisieverts. So it's, I mean, like, it's not something I would want to do repeatedly. I have had to do it repeatedly, and it scares you a little bit, because that DNA or that cell that might be on the border of perfect cell versus a little bit of damage to that cell, that could just push it over the edge. And I mean, that's what ionizing radiation can do. So as a provider, it's imperative that we are very careful and we try to mitigate the risks ahead of time. So just because you have shortness of breath doesn't immediately assume, hey, let's go jump into that CAT scan. It's not, it could do more damage than it could do good. So, it's something to consider.
Absolutely. That's a delicate balance. And there's a lot of contention. If you look up some reviews and stuff between providers, there's a lot of contention of when and when not to do CTs, specifically because of the risks. So female breast cancer is the #2 cause of cancer-related deaths for females, and the #1 newly diagnosed cancer in the United States for females. This is a trend that has been going on for several years. Overall, about 12.9% of women will be diagnosed with breast cancer. So that's an alarmingly high rate. So if there's a screening you want to be paying attention to as a female, I would say breast cancer is right up there.
Well, I mean, we just lost a real pioneer in toxic exposures. Dr. Kate Hendricks Thomas. She came back from Afghanistan after spending. She was in Iraq. She spent a long time in the Marine Corps as an officer, and she was screened. Her provider said to her, "Hey, given your risks, we think you should be screened for breast cancer for mammogram." At 38 years old, she was diagnosed with stage 4 terminal cancer. And so we checked out the data after Kate was diagnosed, and unfortunately, as I mentioned, she passed away, God bless her. But we checked out the data, and it said that after running all the numerics, if you served on active duty as a female service member between 2001 to present day, you are 34 times more likely than your age-adjusted civilian counterpart to be diagnosed with breast cancer. 34 times. So that's definitely a concern. And I mean, it has a lot to do with various things, whether it's hormonal, endocrine-based, it can be anything and everything. So, always keep that in mind and understand your exposures. It's imperative.
Yeah, absolutely. And, we look at unfortunately, just like you mentioned, it took a doctor saying a lot of times early cancer doesn't have symptoms. So it's really up to you to be doing your own self-exams and keeping up with those screening things and talking to your doctor about those exposures. Because had the doctor realized earlier, maybe they would consider doing it earlier and maybe being able to catch the cancer before. Because the survival rate plummets. Anything beyond that localized area, it starts to plummet significantly. There have been great strides, though, in survival rates for breast cancer. Not all the news is bad. 5-year relative survival rate has increased from 76.3% in 1975 to 92.1% in 2015. So that is a long period of time, but that's a really significant increase in the survival. And then following a slight decline, the rate of new cases have increased from 128.1 in 2005 to 135.6 per 100,000 in 2015. So for whatever reason, for a small period there, we were starting to see a bit of a taper off. Looked like breast cancer might have been starting to decline, but not so much now. It seems to be coming back and increasing.
Well, the other thing is the BRCA gene too. If you have a familial history of cancer, especially breast cancer, I know I do in my family on my father's side, and you can actually go get a blood test and screen for the BRCA 1 and 2 genes. And thankfully I was negative, but those little things, those little add-on tests to typical blood work can make a huge difference in understanding your exposures and potential risk factors that are not controllable. You can't necessarily control your DNA. So it's imperative to, ask those questions, understand your family history and go from there. So.
Yeah, and then, we won't try to bore everyone to death. This is a very word-heavy slide here. The part that I really, if there's something to take home from it, it would be just understanding the actual screening protocol. So So U.S. Public Health Task Force says that women over the age of 50 should consider either annual or biannual mammograms. I believe it was, I forget which group it was. One of them had previously been not recommending the annual. So I'd have to look back at that. Screening at 40 to 49 years old is a personal decision and should be carefully considered with your physician. So understanding if you're high risk, understanding if you have a familial history, understanding if you have these exposures that might be related to an increase in breast cancer rate would be where that decision-making process would come in with your doctor. A false positive, like say if we do a mammography and it shows a density that is suspicious for cancer. So we might see something that looks suspicious. So they're gonna not only then they're gonna tell you that, hey, I see a suspicious lesion on the breast, and the next step would be I need to biopsy it. So you know, we invasively take a piece of that, and then we have to send it out and have it looked at by a specialist. So that's a lot of anxiety. That's a lot of
It's unnecessary stress.
yes, and I know that stress. I try to explain that because you know, if you're looking at breast cancer, I think that saying stress, you know, well, a little bit of stress is worth me knowing whether or not I have cancer. But when do we do the next mammography after that? Because a lot of people have benign lumps in their breast. Most lumps in the breast tissue are benign. So even if you're in the shower doing your self-exam and you feel the lump, don't freak out. Talk to your doctor about it. But odds are it's benign. So the high risk, considering a breast MRI and yearly mammography as early as age 30. So this one, I didn't want to get too specific with this one. This is something that you really need to have that relationship with your doctor and take that time to discuss the pros and cons. As early as 30, that's pretty young. But if you have a significant family history, especially of early onset breast cancer, because some people will have, you know, now Miss Kent, you know, her children or her family, that's something that they need to be noting specifically. Hey, mom or whoever passed related to this.
And how much, per question, how much radiation is in an MRI? Zero, because they use magnets. So MRIs, although they're 10 times more costly, they are extremely imperative in identifying, and it offers zero radiation because it uses magnets. So that's a fun fact. I didn't know that until I went to school. So fun fact.
So there's the BRCA gene that we talked about earlier. You know, we kind of touched on that, being over 50 years old. These are statistics that are taken over time. These are the people that we started seeing over time, which show a trend toward being more likely to have the breast cancer. So people that had the dense breast, again, there's some contention to that, but it's still on there. Personal history of breast cancer, no contention to that. If you have a personal history of breast cancer, if your mom or the guy, you know, first or second generation there, you definitely need to consider getting screened. Family history of ovarian or breast cancer, previous radiation therapy, that alone is something that could be enough to even go get screened. First pregnancy after the age of 30, not breastfeeding, no full-term pregnancy history, ever being on hormone replacement therapy, being overweight or obese after menopause, and then physical inactivity. So that kind of goes back to that primary prevention there. There are some things that we can do to prevent, to decrease our odds. Exposures, you know, things like benzene, BPA, flame retardants, ionizing radiation, PACs, PFAS, pesticides, DEET. Those can all have some level of impact on breast cancer. And a lot of that really is still being researched. So it may still be, some of the information still be relatively fresh too. Now we have cervical cancer. As we discussed earlier, I think I mentioned it earlier, HPV is the most common STI in the US military. HPV is also like the singular indicator for having cervical cancer develop in the future. So having a history or active infection of HPV. Most common age of diagnosis being 35 and 45. And then high-risk HPV infection is most common in those between 25 and 34 years old. So this is a pretty young demographic, especially when we're, you know, that's where the vaccination, we can go back and talk about the vaccination. If you haven't had the vaccination, as late as 26, I think they recommend for the catch-up vaccinations. Beyond that, you can talk to your doctor. Some rare cases, they still recommend it. But for the most part, it's 11 and 12 years old, they start recommending people get this vaccination. And with the improvement rate, it's highly recommended. Active duty service members are more likely than their dependents or retirees to have the high risk HPV. So we don't know what the study that we looked at to get that information. We don't know exactly. They haven't been able to isolate the variable for it, but it was an interesting fact to find. And then from the information that we looked at, HunterSeven was looking at some. This was a FOIA request, and we did find that 45.6% of all of the cancer diagnosed during active duty were cervical cancer. I think that was the most shocking statistic that we pulled from any information that I've looked at so far with HunterSeven. 45.64%. When you're accounting for how small of a demographic females still represent in the military, having them represent such a much higher percentage of total cancers, honestly that's terrifying.
And then not only that, but you can see the numbers when we looked at 2001 to 2021. You can see the rate of cancers go down. Especially, I think it was beginning around 2007, 2008. You start to see them decrease because that's when the vaccine was first able to come out, and children that were 14 years old was in 2004. So it's really ironic to see that trend go down. So I mean, that's pretty important.
Yeah, absolutely. And if you can't tell, we're really trying to nail home the importance of the vaccination with primary prevention. So here is a really good illustration of the survival rates at what timing that we catch them. So 44% of diagnoses are made in the localized area. Sorry, I wrote that kind of weird. I apologize. Yeah, 45% of diagnoses are made when it is local. So that means it hasn't left. It's sometimes called like encapsulated. So it's in a single location, hasn't spread to any other organs or any other tissue outside of that spot. There's a 91% 5-year survival rate for that. 36% are distant. So that means it's now spread to beyond just one organ. It's spread to distant organs or tissues. So this is giving them a 59% 5-year survival rate. And then, well, excuse me, I think that was supposed to be. Sorry, I think I mistyped that there. Yeah, so apologize. But yeah, you can see, so stage 1, 2, and 3, and 4, you can see that the survival rate, I'm pointing at my screen like you guys can see it, I apologize. So 91% if it's caught really early on, 59% if it's caught a little bit later, and then 17.1% if it's caught at the actual distant metastasis. So the survival rate, 5-year survival rate, is the percentage of people that would be expected to survive that amount of time. So significant. So for cervical cancer screenings, these are relatively non-invasive, as meaning they're not, cutting anyone open or doing any kind of major scans, but these are uncomfortable examinations, but they're very necessary examinations. Pap screening with cytology alone is recommended for every 3 years, starting at 21 to 29 years old. And then PAP with the high-risk HPV testing every 5 years from 35 to 65 years old, or with co-testing every 5 years. So that would be something you want to talk about with your doctor and see which one fits best for you as well. Risk factors, we embolden the HPV infection, sexual history, smoking, immune deficiency, chlamydia, long-term oral contraceptive use, multiple full-term pregnancies, under 20 years old for your first full-term pregnancy, and then low socioeconomic status as well, and then having a family history. So not a lot of those are super preventable, but there are things that we can do to mitigate those risks. Using condoms and contraceptions and things like that, you can kind of lower it, but it doesn't totally get rid of the risk of either. All right, then lung cancer. 55% of cases are detected with distant metastasis. So over half. that means that over half of these cases with lung cancer, we've already spread outside of the lung and we went to other organs. Lung cancer is one of those that you can live for quite a while with having a nodule or a tumor in your lung. You're breathing okay. You might even, it might be such a small change in how you're breathing that you may just not even notice it. But again, without screening, we are not going to catch those.
There's so many interesting things about lung cancer too, because you know, a lot of people assume that quote unquote burn hits are the biggest concern for lung cancer, which is actually false. And, you know, it's the people that we least expect. Like we have a high prevalence of individuals who served on flight lines and those who are special operations and infantry who have lung cancer. And when you think about the correlation, you know, on the flight line, you're exposed to so many different fuels that have been combusted. And so that's an exposure right there for lung cancer. And, you know, benzene's a known carcinogen, which is a primary additive, and it's a primary chemical per se in JP5 and JP8, it's, along with kerosene. And kerosene's the same thing, you know, and it's a risk factor. So that's understandable. When we considered infantry and we considered special operations, a lot of these people were exposed to close quarter combat, you know, and as Jack said, it's that shooting of the firearms. It's the blowback of the different particulates from firing a weapon, and close quarter combat. And, you know, being in Iraq, Afghanistan, you're exposed to different things in terms of, you know, not only the sand, but asbestos and the buildings. And the other big thing that a lot of people miss out on or misunderstand is the risk for driving down the road in IED blast. So if you're involved in an IED blast, you have your primary and your secondary exposures, which is the actual physical injury, the secondary concussion, but also that tertiary airborne exposure related to particulate matter, which places you at an increased risk.
Yeah. So all of that. Another issue, though, is that one thing that we can notice is that it when we detect the cancer, so 55% are detected with the distant metastasis. At that state, it's only a 7% 5-year survival rate for lung cancer, which is an abysmally low. There's very few cancers that have that abysmal of a survival rate. 12.3% of all new cancer cases account for 21% of all cancer deaths. So this is a nationwide problem. This is a worldwide problem. And depending on what part of the world, you know, we can talk about the different types of exposures that we can relate to different, just geographically where, you know, we can kind of see more incidents of lung cancer. But one important thing I really want to take note of is that 59.7% of low dose CT scans were positive. And of those, 97.5% were false positive. This was after this was ruling it out through biopsy. This was a study in 2017. This kind of hits home with the importance of targeted screening and not just kind of shotgunning and then checking yourself every year for lung cancer. Currently, and this is an important part for veterans to take note of, because this is an example of when there's other types of exposures that you might be more apt to start screening with your provider. Adults 50 to 80 years old with a 20 or more PAC year history, or who have quit within the last 15 years, should consider a yearly low-dose CT scan. So, believe it or not, even in the U.S. Public Health Task Force recommendations, it's specific to smoking. That's how much of a predictor smoking is for having lung cancer. So if you have other types of exposures that your doctor might be able to relate to that, if you had multiple deployments to, you know, Iraq or Afghanistan with different the plethora of exposures you might have, before you start having those symptoms, your doctor may consider actually doing CT scans. But again, this is something that you have to talk about and make that relationship with them to do. Risk factors. If I could highlight it anymore, I would, but smoking, familial history of lung cancer, radiation therapy. Those are the primary risk factors for it.
And these exposures, what's interesting is that a lot of these exposures actually occur stateside as well. And, you know, radon, it's interesting about radon is that the older your house is, and being from Massachusetts, the older your house is, the more likely it is to have radon in your area. which when radon occurs, it gives off kind of like that uranium type of exposure, which is known to cause cancer, or lung cancer specifically. And so all these things are things that can also happen stateside. So you don't necessarily need to be deployed to be exposed. Silica, same situation. I mean, it's more common and smaller and more hazardous overseas in Iraq, but diesel exhaust, arsenic, asbestos, radon, chromium, all of those things occur on base on a daily basis. So, don't think if you're not deployed, you're not exposed. There is always that risk factor.
Yeah, absolutely. And we're learning so much more about these different types of exposures, how it's not just smoking, but there's so much more research to be done on that to really narrow it down, to get people to really buy into the reason of screening more frequently. And when do we screen more frequently, knowing how big of a risk it is to overdiagnose or overscreen for people.
But a lot of these things like radon, you can grab a $18 radon test from Home Depot, and it's just like a COVID test. It's point of contact, and all of these things you can easily do. So we'll provide more information about that in a handout. But there's so many things you can do on a preventative, cost-efficient level that can help you in identifying these risks.
Yeah, absolutely. So cancer screening guidelines, we've talked a little bit about, we kind of focused more on the U.S. Public Health Task Force. If you go online right now and you type in screening guidelines for lung cancer, you're going to see, I think, 2 or 3 different ones that are going to pop up, and they may vary just a little bit. Cervical cancer, there's actually quite a bit of variation if you look at those between the different groups that recommend that. CDC does a good job. If you are interested in looking at all the different guidelines, go to the CDC website. They actually have a chart that breaks down the different types of screenings by the different recommending bodies. As we talked about earlier, your healthcare team doesn't know anything that you don't tell them. So if you go and you do that radon test at home and you tell your doctor, hey, did a positive, radon positive is through the roof in my house. Now, as a provider, I can think, okay, maybe there's some unique things that I can screen this person for, because outside of those guidelines, there has to be a reason that I would even consider doing that, because the guidelines go on the average person with average exposure and nothing else. And then, we healthcare providers, if there's any healthcare providers listening to this, you can't make any informed decisions if you're not informed yourself. So take the time and learn about this. Being exposed to just learning about HunterSeven. I remember when I first was exposed to HunterSeven as an entity, I was surprised every single time I opened up the website, or every time that I, would see one of their educational materials. I was surprised to learn something else. And me, I'm a pretty, I'm pretty critical of anything that I read. So I would tear it apart and try to find problems with it. But the problem was that I couldn't find problems with it. That was the issue that I was running into. And that's what made me more inquisitive. And that's what made me want to get involved in this. So as a provider, look into it, and I think you'll be surprised. And then, the tools on the website. We have tools just like you see there. There's the one-pagers that are great resources. And then there's even the heat map too as well that you can utilize on the website. And I think we kind of already spoke on those. I think I hit those on the last slide. Knowing your exposures. So the only way to know your exposures is to educate yourself. As providers, educate yourself. As veterans, educate yourself. Active duty service member, educate yourself. Talking to your provider. If you have one of those providers that limits your time to 3 or 4 minutes in a visit, get a new provider. That provider is not doing you a service. Expect more out of healthcare. Expect that your provider, when they talk to you, they're listening to you, they're taking notes. They're building a rapport. They know something interesting about you. When they lay their stethoscope on you, they're listening to your lung sounds. This isn't all providers, but right now, unfortunately, there are a lot of them who are getting away with this, and they have been for a long time. And then if you're not satisfied with something your doctor says, get a second opinion. This is not something that you're not going to offend. A good provider will not be offended by this. If you were my patient, you say, hey, I don't believe you. That's fine. Go to another provider. Don't provider shop. Don't don't get in your head a preconceived notion that it is cancer and then try to find a doctor who's going to tell you it's cancer, because eventually you'll probably find a doctor who tells you it's cancer. Yeah, right. And then you end up going down a rabbit hole and you end up getting screened and you didn't need to be screened. Then you end up biopsied and, with a pneumothorax or whatever else, there may be.
So, awesome. And that concludes part 2 and our hefty citations right there. But I will close this out and allow to open up for questions, and also mention that we will be having part 3 on June 22nd, and that email will go out and we'll send out a link. But we're excited for this one because it's going to be a open forum type of approach with actual veterans diagnosed with cancer, including a female, Brandy Benson, who's an author, a cancer survivor, Ewig sarcoma, a fighter pilot who served as on American Ninja Warriors, the TV show, and also a Navy SEAL Team 6 dog handler operator who just beat colon cancer. So a lot of good people coming onto that one, and you can ask them as many questions, and I'm sure they'll tell you how they got cancer. And it is so impressive, the things that you'll hear. So definitely sign up for that one. But now, we'll open it up to questions.
Thanks, Jack and Chelsea. The first question we have is, if we catch and treat a cancer with chemo and it doesn't carry the DNA fingerprint, what are the statistics of reoccurrence, specifically for veterans, assuming its toxic exposure decreases?
So that's an interesting one. So a lot of cancers, and I actually have experience with this in dealing with one veteran in the sense that they thought it was a genetic predisposition where it was actually a DNA mutation. And so identifying the cancer itself at its primary histology and cytology is critical, seeing where that root cause is. So unfortunately, if we can't identify whether it's a genetic or genomic predisposition versus a cellular DNA mutation, it's not going to be treated accurately. And that's where a lot of these things happen. So the chance for reoccurrence based on toxic exposures is usually an alternation in DNA based on either radiation or depletion, or a cell that can't fully develop because of ionizing radiation. But the risk factor of reoccurrence depends on the cancer and the location of the mutation. I know that for sure, but considering there's 23, how many chromosomes is there? 20. There's a lot of chromosomes. 23 chromosomes. So, an alteration in 17 might differ in the prognosis or treatment in an alteration in 4, and so it makes a difference. But is the reoccurrence rate high? I mean, I know in testicular cancer it is, and it depends on the stage too. If you're stage 1, the reoccurrence is probably fairly low. If it's stage 4, absolutely, there's a high chance of reoccurrence. Toxic exposure related cancer is very aggressive, and unfortunately, a lot of them are misdiagnosed and prolonged diagnosed. So they get to that late stage, and it's really hard to control them.
There's a lot of variables to that question. It's a very, very difficult question to answer without having, a full, picture in front of you too. So.
And then the second question that came early on in the discussion was, are there any specific screenings done for cancers at the moment in place before deployments?
Before deployment, are there any cancer screenings? Not necessarily. I mean, it's been a while since I've been in the military, but I remember my last PDHA was typical blood work, so a CBC, a complete blood count, and then we did our BMPs, basic metabolic panel. But it's very rare to screen for cancers if you're asymptomatic in the military. So that simple blood work might trigger something like, oh, your white blood cell count's extremely high or extremely low, or your red blood cells are extremely high or extremely low. And that might kind of throw off something to a provider like, oh, what's the cause of this? And they dive more deeper into it. But same thing, I think, with like LFTs, your liver function test, and your renal function test, your kidneys, all those things will be out of whack, but not usually in early stages of cancer, more so in late stage of cancer. So pre-deployment, it's not necessarily screened for aside that basic stuff, because, if you think about it, military is the number one, top 1% of our nation's country. We're supposed to be the healthiest, the fittest, and all this stuff. So you don't necessarily, in ideology wise, you don't necessarily look into that, if that makes sense. It's unfortunate, but
don't want to be terrified. A lot of information that we just gave, this is terrifying information. And every time we do it, there's at least a couple of people that'll start trying to self-diagnose, go, oh my God, I probably have cancer, or they freak out about it. Deployment itself wouldn't be an indicator for me to do any type of specific screening. I wouldn't say, hey, you're deploying, I'm going to screen you for this type of cancer before you go. I screen for a whole lot of other things, but not necessarily cancer.
Thank you. We don't currently have any other questions. If any of the participants would like to submit questions, we can stay online for a few more minutes.
Well, there's a question on there. One of the last slides showed a screenshot of 4 flyers. Yeah, so if you go on our website, check out our website and you go to education. Education will have some, if you scroll down to the bottom, it will actually give you all of those handouts to download. And it will also give you a cancer screening chart that myself and Jack physically created ourselves based on your exposure risk. So we'll give you the cancer, the type of symptoms, the testing, and then actually the exposures related to that based on clinical iteology. So, and then Betty asked, does lung cancer from asbestos have a specific signature? That's a tough one. I want to say it depends. So what I've seen with asbestos specifically is similar to like a scarring in the lung tissue internally. So what we've seen on like cytology slides is a lot of what it kind of looks like a broken glass in a way. So with lung cancer and with asbestos-based lung cancer, that's usually what you see. So I mean, you look, it's like silicosis. It's a tough one, but I'll send over some pictures for comparison. We'll add those so we can do that. But yeah, we can definitely I'll get that to you, Betty. Don't worry.
So if that is all of the questions, then I'd like to say thank you to our audience and make sure that everyone knows that all of the questions and answers and links will be provided to all of the attendees, as well as on our website, each of our websites. We may work on the audio for this one so that we're representing, just to make sure that everyone's getting full answers. And we'll look forward to our roundtable. It sounds like a really wonderful next program.
Yeah, there's some amazing stories. I mean, Billy's story as a SEAL Team 6 dog operator and how he got cancer based on, it's incredible. Pilots, I know Betty, I adore her. She lost her husband to cancer, who was a pilot, and there's a huge initiative and push towards that. So we have a really great segment for that coming up. But any other questions you guys have, if you want to, send the Women's Memorial a direct message or an email, they'll get it to us, and we'll give you definitely an in-depth reviewed answer. So.
And we know you're very, very busy with more and more programs that you are putting on. So if you ever care to tell any of your audience more of that, you're welcome.
Oh, I don't even know what month I'm in. No. Megan, do we know what we have coming up next?
You have an event this evening in DC.
That's right. That's why we're both
a few hours from now at the Press Club.
So that's quite remarkable. Sharing more and more information that's so important to your audience, to our military.
There's a question in the chat. I know there's a doc attending. Is there a list of docs nationally who have a specialty? Ooh, that's a good question. And yes, I can definitely, can we write that question down? That's a good question.
It'll be captured.
We do have a list of providers that we actually work with for second opinions nationwide, and a lot of functional medicine doctors, and how those docs, yeah, that's a good question. If we have any providers that are interested in this, jump on, shoot us an email or a direct message, and we can definitely talk through it and be sure, because we are very short on doctors that care clinically about post 9/11 veteran health, and not necessarily that they don't care, but that they don't understand. And so the more doctors that are willing to listen, the more nurses and providers, is extremely helpful. Please shoot us a message, and we'll definitely work with you and get you all the information you need to be a clinically sound post 9/11 veteran healthcare provider.
And there is so much information on your website. Like there's so much good research, connection, lots of endorsements and stories of your care.
We try. Social media, we try to put out a lot of data too, a lot of good screening stuff. I know you guys do as well. So we'll definitely throw you guys, some information to share.
Wonderful. We count on it. All right. Well, we thank you very much.
Thank you.
All right, bye-bye.